Hi, my name is Sophie Rubfenfeld, and this is my presentation for Biology in the News on the topic of sepsis. So first, a quick overview of what sepsis really is and why I chose it. I chose sepsis partially because my father treats it often, as he is a pulmonary critical care doctor, but also because it has such a huge impact on the world and people's lives, despite so few people knowing about it. So a quick background on sepsis. Patients range from sepsis to severe sepsis to septic shock, and septic shock being the most elevated level and providing the least likely chance of survival. Sepsis is an overwhelming immune response to an infection. It occurs when the chemicals released into the bloodstream to fight the infection cause widespread inflammation, and the inflammation leads to bloody clots and leaky blood vessels. So a few causes of sepsis are infections, and though any type of infection can cause sepsis, the most common infections include pneumonia, abdominal infections, urinary tract infections, and infections of the bloodstream or bacteremia. In addition to the infections themselves, common symptoms may also signal doctors that a patient has sepsis, severe sepsis, or septic shock. The main symptoms of sepsis are an infection with fever, chills, and a rapid heart rate. However, if the patient has all of the symptoms of sepsis, along with a decreased urine output, low platelet count, difficulty breathing, and abdominal pain, they most likely have severe sepsis. Finally, if the patient has all of the symptoms mentioned above, in addition to low blood pressure that does not adequately respond to fluid replacement, the patient is in septic shock. Once a patient is diagnosed, they are at risk for several complications. Over 1 million cases of sepsis occur each year, and up to half the people who get sepsis will die. Because of the widespread inflammation, blood flow is poor, which deprives the patient's organs of the essential nutrients and oxygen they need to function. In addition, blood clots caused by sepsis can form in organs, arms, legs, fingers, and toes, which lead to varying degrees of organ failure and tissue death. And for those who do survive sepsis, many suffer from post-sepsis syndrome, which is a term used to describe the group of long-term problems that some people who survive sepsis or severe sepsis endure. For the most mild stages of sepsis, antibiotics via intravenous therapy or vasopressors are given in addition to low doses of corticosteroids and insulin to maintain stable blood sugar levels. Drugs that modify the immune system response, along with painkillers or sedatives, are also given. If the inflammation appears to be spreading, however, doctors try to treat the infection, sustain the vital organs, and prevent a drop in blood pressure. Many patients receive oxygen and intravenous fluids. Other types of treatments, such as respirators or kidney dialysis, may be necessary. Sometimes surgery is needed to clear up an infection. Throughout this process, I have had the ability to review the research of many scientists. In this section, I will discuss the many different research papers I was able to look at. So, throughout my research, I came to understand that the intended goal of the scientists' research was early detection, because most people recover from mild sepsis, but the mortality rate for septic shock patients is nearly 50%. I began with the research of Wolfram Ruff and Frank Nissen. Their experiments indicated that it is a cell signaling component of the coagulation cascade, or activation of the coagulation system, that triggers the severe inflammation of sepsis. Ruff and Nissen also discovered that the clotting activates the immune system to prompt sepsis, and that a variety of cells in the immune system of mice are irritated in the lymphatic system rather than the bloodstream. Ruff and his colleagues also discovered that the downstream components of the protease activated receptor signaling pathway. Protease is an enzyme that breaks down proteins. They identified that the protease signaling on the dendritic cells induces the production of sphingosine 1 phosphate, or S1P, a lipid with a biological effect that activates another receptor, the S1P receptor 3, or S1P3, in knockout mice or genetically modified mice that lack the S1P3 receptor. They showed that dendritic cells are also responsible for triggering decimated intravascular coagulation and sepsis. Decimated intravascular coagulation is a condition where blood simultaneously clots and leaks from the blood vessels. Through the connection between the S1P3 and PAR1, dendritic cells are caught in a self-sustaining circuit where they activate coagulation to produce severe systematic inflammation. I continued my examination with the research of Kota Viramana and Professor Satish Srivastava. Professor Satish Srivastava and her colleagues injected mice with LPS, or lipopolysaccharide, to produce the conditions of severe sepsis. They then watched as the mice experienced major decline in heart function and large increases in heart-damaging inflammatory signaling molecules. However, when examining the mice who had received the aldose reductase inhibitor, the scientists found that blocking the enzyme's activity restored the heart's ability to pump blood normally and allowed mice to injected with otherwise lethal levels of LPS to survive. From this evidence, the scientists have concluded that an aldose reductase inhibitor will have a major effect on the impact of a patient to survive and deal with sepsis. This conclusion has provided the field of science with yet another alternative as to slow down or stop deadly and incurable diseases such as sepsis. Finally, I examined the research of Claude Marin, Xavier Viveland, Mark Leone, and Xavier Thuron. Through their efforts, the scientists uncovered that the contradiction of the previous notion that norepinephrine causes low blood flow to the organs, norepinephrine as part of hemodynamic management, may save lives. The scientists also uncovered that pneumonia as the cause of septic shock, high blood lactate concentration, which appears as a signal that organs are not receiving enough blood, and low urine output when admitted to the hospital are strong indicators of a poor prognosis. Multiple organ failure is confirmed as a reliable predictor of death in septic patients. Also, as a part of my research, I interviewed my father, Dr. Josh Rubfenfeld. One of the questions I asked was, how would you say sepsis treatment has evolved since you first learned about it? He responded saying, we have become much better at supporting patients' blood pressure with IV fluids that we are now starting to worry that we give them too much fluid and later on cause problems with their hearts. Another question that I asked was, if you had the ability to create a study of your own on sepsis, what would you look into? He then responded, either the ideal blood pressure to maintain my patients at or the ideal amount of fluid to give somebody, as it is not to cause issues by giving them too much or too little. I found this particularly interesting because when asking these questions, I was able to gain a broader understanding of just how much research has yet to be done when it comes to sepsis and its prevention. It has been estimated that if the United States as a whole achieved earlier sepsis identification and evidence-based treatments, there would be 92,000 fewer deaths annually, 1.25 million fewer combined days spent in hospitals annually, and reductions in hospital expenditures of over $1.5 billion. This research is helping the United States come closer to these numbers, therefore it is very significant. And finally, these are my sources that I used throughout my research. This includes all of the papers I presented, and I would just like to add on that I also interviewed my father.